Hello, my name is Patrick Osika, and this is my client Liz Maltz. I'm going to do a demo today on how to treat herniated disc. We have, in this case, a double herniated disc, L4 and L5. There's a lateral herniation, and then S1 and L5. There's a ventral herniation. So this is a very complicated case, and I will demonstrate on how to go about approaching that. Also, she had an injury a year ago in which she hurt her neck. So I will also demonstrate an upper body evaluation and treatment at the same time. So Liz has come to us now. This is like her 14th treatment that we've had, and over a 2-month period from when she first had the herniation. The neck injury was a 1.5 years ago, and it never really was properly rehabilitated, so it still gives her pain. And of course, after she had the herniations in the low back, it started acting up again, which is oftentimes the case with spinal injuries. So the first thing I will do is work the upper traps and the splenius capitis and the cervical spine and the shoulder to relieve any tension there before we actually go and treat the side that is getting impinged on the C7 and C6 thoracic outlet and the brachial plexus on actually the left side. So we always want to release the tension on the opposite side first, so that when I get over there, I will have less pressure in my way to work on the site of the inflammation. I'll tell you a little bit about Liz as I work. She is 35 years old. She has had back pain pretty much as far back as she can remember, from when she was 7 years old, and she was rear-ended when they were parked on the side of the road, and she was in a position in which she was turned to the side when the car hit. And ever since then she had back pain and was never properly treated or even diagnosed until recently, when finally, all of a sudden, after cleaning her house one day, the next morning she couldn't move. So we have an MRI, and in the MRI they found 2 herniated discs in the low back. So we know what we're dealing with. In some cases, we have people come in like this, and we do not know what's in there. We do not have the benefit of MRI, but still, we will take an evaluative approach to assess the situation, and that's very important when you have a client like this, that you do not do any kind of therapy that will make it worse, because oftentimes people with herniated disc will have excruciating pain even from just bending down to tie their shoe or even getting in and out of a chair. So normal therapy in many cases cannot be applied. So what we do in Hoshino Therapy, we are a specific therapy for treating people in chronic and acute pain. And there is a way to do that which I will demonstrate here today. Now, when Liz first came in, she could hardly move. We barely got her up here on the table, and now after 13 sessions, this is the 14th session, she is now able to be off the painkillers, which she was on for the first 2 months. We took her off of them about 3 weeks ago, and now she's been stable without any anti-inflammatories or without any painkillers, but she still is in a lot of pain and will need still further rehabilitation. What I'm doing now is I'm going through all the muscle groups in the upper body, releasing any tension or adhesions that I might find there along the way with our 270-point evaluative therapy and diagnosis. What I'm doing here is I'm looking for any pressure points which are particularly sensitive, which will tell me about where I need to work in order to relieve the pressure on the cervical spine. A lot of people fail to recognize how important that is to work not only on the site of the injury, but even more importantly, around it, on the muscles and the joints surrounding it, because it is there where the dysfunction starts to spread. And oftentimes the site of inflammation, you can only work on it so much. So the dosage is very important. If you overstimulate an inflamed nerve, you will surely make it worse. So oftentimes when you have inflammation on a nerve or a disc, the actual proper method of treatment is not treat that area at all, but treat distally until the inflammation is relieved, and then you can work on it safely without any risk or harm. So I'll do a basic assessment of the glenohumeral joint and see how it's functioning. And this one has all the movement in it that we would expect. So now I'll move to the other side. And I don't know if you can see on the camera here, but from my vantage point, I can see that this shoulder is a good inch higher pronated forward than the left. Now she has the same tendency on the left side, although not as sharp. So one of our goals posturally here to correct this, which is not all due to the injury, some of this was here congenitally. This is her body and her seated posture of her upper body, which is part of the reason why she's vulnerable to injury here, aside from the fact that a coat rack fell on her shoulder. But I don't only want to treat the injury, but I also want to treat the posture in order to get a truly better result. Not only to treat the injury, but also the underlying conditions which create the injury, like the pronated shoulder, which eventually down the line will make her stronger and healthier in the upper body and prevent this kind of injury from happening again. So on this side we see there's a lot more inflammation. I can tell this by not only her pain level, but the thickness and the elasticity in the tissue, and also the sensitivity of the pressure points. We here find that on C1 and C2, slightly subluxation to the left, and around the scalenes, there is a lot of tension where they have become adhered to the transverse processes. So I will gently relieve them, careful not to overstimulate that area because it's close to the nerve and the nerve is still slightly inflamed. I can tell by how sensitive she is to the pressure there. One of my objectives here is to release the pec minor and also the levator scapula, which are in spasm still, and I know that from the last treatment when I worked on her. Although now they have improved by at least 40%, but still they are contracted and in spasm. So, in action now, I will work on the upper traps and the levator scapula and the splenius capitis and anterior scalenes, which are very important for releasing the lateral aspect of the transverse processes of C1, 2, 3, and 4. One has to be very careful working around these areas that they do not overstimulate, because you can very easily bruise an inflamed or entrapped nerve. So sensitivity is the key into dosage, so you know how far you can push the point without overstimulating it. Right here, between C2 and C3, I find the inflamed nerve, which Liz can tell you is very painful, even though I'm applying less than a pound of pressure. So it's very important, areas like that, not to overstimulate them. Just a little bit of stimulation is all that's necessary. And then you will go distally from the area to relieve the pressure from the thoracic outlet, which here again is in spasm. And I can tell by the reaction of the muscle tissue under my hand and how it jumps back when I push on it. So I never want to force. I want to use just as much pressure as the muscle and the nerve can tolerate at this time until the inflammation goes down, and then I'll be able to work on the area with deep pressure safely without risking injuring the nerve. Now, because this injury has been here now for a year and a half, it has had time to create lots of adhesions between the muscle fibers and the tendons. So this then, over time, becomes more of a problem than the original injury, and also prevents the nerve from recovering, because these muscles, like the pec major and minor, which have gone into spasm around the thoracic outlet, now create constant pressure, re-injuring the neck. Now I will work on the lats and the teres major and minor. I make sure that I put the arm in a position that allows me to do this, and also that is anatomically correct, lining up with her spine, so that when I do work on the muscle that I am targeting, I am also aware of the proper alignment and posture of that joint. I don't want to just allow it to work in a bad position. I want to actually put it in a correct position, and then there, in that position, in that anatomically correct position, is where I will try to release it. It's little details like that that make the difference in your results as a therapist. Now we will treat the anterior deltoid and the long head of the bicep. In Hoshino therapy, we have a special hand technique for the safety of the therapist's hands and also for the comfort of the client. We never approach with a pointy fingers or pointy thumb. We always use a whole hand, and then we apply the pressure. This makes it a lot more comfortable for the patient when you have to work on areas that are very sensitive and inflamed. Also, I cover more surface area, I compress more muscle tissue and lymphatic and circulation, as well as I warm up the area with the heat from my hands. There's a lot more heat if I have my whole hand applied than if I just have a couple thumbs and fingers. Moving on to the brachialis, which all these muscles I find have lots of adhesions. And I'm comparing it with what I found on the right side and using the right side as my guide as to where this stuff should be and the proper tension and balance between both shoulders and the neck and the pectoral girdle. I look for balance and symmetry and muscle tone. I want to see as even a balance and symmetry and muscle tone and spinal alignment from left to right as I can maintain. Now here is a very important area for the insertion of the triceps, short head and long head, and the middle head. These attach on the back of the scapula and work with the levator scapula and control the position and angle of that upper back part of the neck. So if I find a tricep in spasm, I know that I have to release this in order to get a very good result up here. So we are actually working on the neck by working on the tricep. So a lot can be done even if a person has an acute whiplash or a herniation in their neck. You never actually have to touch it to treat it. And that is one of the keys to our therapy with working with acute injuries. Which the most important thing is not to make it worse, not to aggravate the injury, and yet relieve the pressure on the spine so that the person can recover quicker. Now moving on to the flexors of the forearm. And here I find that same tension that is coming through the thoracic outlet and the cervical spine, because as those nerves get compressed, it causes an involuntary muscle contraction throughout the whole thoracic outlet, which then travels down all the way into the hand and even the fingers. So when you find these reflex points in the hand, you can actually relieve different points on the neck by working as far down as the hand and forearm. Here I find part of that entrapped nerve in C2 and C3. I know this from experience. And the pressure here, on a scale of 1 to 10, if I had an average arm here, I would expect to find a pressure of 3 or 4, or even 5 would be normal. Hers right here is up on 8 and 9. So I want to always check these points and make sure that I see a reduction in the pressure and the sensitivity. And that will then let me know that my work has been successful. If I do not see these changes in the pressure points, then I know that my evaluation has to be reassessed and my approach has to be reevaluated so that I start to make progress. This is our focus as a therapist, and a result-oriented therapy. If we do not get results, then we are not accomplishing our goal. So we want to always see progress, and that lets us know that we are doing the right thing for the problem. We do not want to rely just on our intuition or our past experiences, because each person can be uniquely different, even though they have the same injury.